Hello, wonderful staff of the Northwest Kidney Center, particularly at the flagship unit in Kent, but also with an acknowledgement this month of the Yesler Terrace Northwest Kidney Center unit, which is big and beautiful and provides the high level of care that we've grown to expect from all Northwest Kidney Center units. Today we're going to discuss medications that are administered in dialysis units during the procedure. It's good to be familiar with what is administered to our patients and why. We actually don't administer that many medications to our patients, so the number is manageable and it's good to be familiar with them. There are just two objectives of today's talk. Be familiar with the medications that are administered during dialysis and recognize their purpose and side effects. Medications we'll discuss today are heparin, erythropoietin, vitamin D, ondansetron, loperamide, intravenous iron, antibiotics, TPA, and acetaminophen. Let's begin with a discussion of heparin. Heparin is a naturally occurring polysaccharide, which is a carbohydrate molecule. It's produced by endothelial cells and certain immune cells, including basophils and mast cells. And the main function is to inhibit the coagulation or clotting of blood. Heparin is usually stored within secretory granules of mast cells and released into the vasculature at sites of tissue injury. So in addition to preventing clotting, it may also serve as defense at such sites against invading bacteria and other foreign materials. At the Northwest Kidney Center, heparin is typically administered as a single bolus at the start of dialysis. If clotting occurs, the bolus can be increased, or a mid-run second bolus can also be administered. It also can be administered as a bolus followed by an hourly infusion, usually stopped 30 to 45 minutes before the completion of the dialysis therapy to minimize bleeding following removal of the dialysis needles. If prolonged bleeding occurs at the end of dialysis after the needles have been removed, first step is to reduce the dose of heparin, although all patients with persistent prolonged access bleeding should also undergo evaluation of their hemodialysis access. Specifically, if they have a stenosis or a narrowing of the fistula, that can increase the pressure inside of the fistula and present with prolonged bleeding. Generally, we don't use heparin if patients are receiving some other form of anticoagulation, such as warfarin or apixaban. Heparin comes as either a low molecular weight or fractionated heparin, or as an unfractionated heparin product. The latter is what we administer on dialysis. It's a mixture of anionic glycosaminoglycan of varying molecular size. So it's unfractionated as opposed to being low molecular weight. Half-life is 90 minutes. After 4 half-lives or 360 minutes, heparin is pretty much gone from the body. So it is safe to give to patients even if they are scheduled for surgery the next day because, 6 hours after they receive the bolus, the heparin is completely metabolized. From the 1930s until the 1990s, heparin was mainly obtained from cattle tissue, which is a byproduct of the meat industry, especially in North America. But with the rapid spread of bovine spongiform encephalopathy, or mad cow disease, more and more manufacturers abandoned this source of supply and as a result turned to pigs as a source of heparin. So global heparin production now is increasingly concentrated in China, where it's procured from the expanding industry of breeding and slaughtering pigs. There are some downsides to this. First, we are completely dependent on China for heparin, as we are for many other medications and products. Say in a trade war or a pandemic, this can seriously compromise our ability to do dialysis if we can't get the heparin. Second, the current method of, or by which heparin is produced is very bad for the environment. To meet the medical demand for heparin, China raises about 1 billion pigs annually. And just raising them alone, not counting their slaughter or their transportation of pig products around the world, generates more carbon dioxide annually than the entire automobile industry. Third, the quality and safety of heparin production has been compromised in the past, leading to health problems and even death. In 2008, in the United States alone, there were at least 246 deaths and 785 serious illnesses associated with the administration of Chinese heparin among dialysis patients. Patients presented with shortness of breath, nausea, vomiting, excessive sweating, and rapidly falling blood pressure, as well as life-threatening shock. The heparin contained a contaminant identified as an oversulfated derivative of chondroitin sulfate, which basically comes from cartilage and is often used to treat arthritis. Since oversulfated chondroitin is not a naturally occurring molecule, it costs a fraction of true heparin starting material and mimics the in vitro properties of heparin. So the counterfeit was almost certainly intentional as opposed to an accidental lapse in manufacturing. The raw heparin batches were found to have been cut from 2 to 60% of the counterfeit substance, and the motivation for the adulteration was attributed to a combination of cost effectiveness and a shortage of suitable pigs in China that year because of the swine flu. The point is that history repeats itself, and it would be very helpful if we could either not be relying on China for heparin or come up with an alternative form of anticoagulation. We avoid heparin in instances of active bleeding or situations of increased risk for bleeding. That may include severely low platelet count, GI bleed, major surgery in the past 72 hours, bleeding in the brain, the use of other systemic anticoagulants such as warfarin, a condition called uremic peritonitis. If basically someone is they have an inflamed outer side of the heart called a pericardium as a consequence of being underdialyzed, or if they don't have normal clotting factors. Side effects of heparin include prolonged bleeding, increased risk for high potassium or hyperkalemia, inflammation of the liver, weakening of the bones called osteoporosis, an allergic hypersensitivity reaction, and finally something called heparin-induced thrombocytopenia or a low platelet count due to heparin use. There are two forms of heparin-induced thrombocytopenia, type 1 and type 2. Type 1 is generally considered to be a benign condition. The platelet count doesn't get very low, but in type 2 you can get severely low platelet count, and that's due to preformed antibodies against heparin. These antibodies can cause thrombosis or clotting as well as low platelet count thrombocytopenia. And if you have heparin-induced thrombocytopenia, you should avoid heparin exposure in the future. It occurs in 2 to 15% of patients who are given heparin. Type 2 is much more serious than type 1. Generally occurs within 4 to 10 days of exposure to heparin. The mechanism results in both platelet activation as well as activation of clotting factors of the coagulation cascade. Platelet count tanks quickly, but generally remains above 20,000. And occurs in patients who have never been exposed or after re-exposure after a given interval. So what if we can't use heparin during dialysis? Alternatives include saline flushes, warfarin, which is oral therapy, direct oral anticoagulants such as apixaban or rivaroxaban, which inhibit factor Xa, or factor II inhibitors such as dabigatran. Okay, the next medication we'll discuss is erythropoietin or EPO. Anemia is defined as a reduction in hemoglobin or a reduction in the number of circulating red blood cells. The World Health Organization defines hemoglobin less than 13 for adult males and postmenopausal women and less than 12 for premenopausal women. It's not specifically defined for dialysis patients, although generally the accepted goal is to keep the hemoglobin around 10. Why is anemia so common in dialysis patients? Well, it's because they don't have a hormone called erythropoietin or EPO. EPO is a hormone produced by the kidney which stimulates red blood cell production. Levels in dialysis patients are typically only 1 to 10% of normal. It's responsible for the vast majority of anemia in the dialysis population, although there are other causes. And erythropoietin or recombinant human erythropoietin, which is given to our patients, costs Medicare billions per year. Very expensive medicine. The discovery and production of erythropoietin has an interesting history, and also the Northwest Kidney Center played a part in it. In 1977, a researcher named Miyake isolated erythropoietin, so the hormone, from over 2,500 liters of urine from patients who had a condition called aplastic anemia. In 1985, the human gene encoding for erythropoietin was characterized, which allowed for the industrial production of recombinant human erythropoietin, or EPO. In 1987, a local nephrologist named Joe Eschbach published the first clinical trial of erythropoietin in dialysis patients involving patients at the Northwest Kidney Center. And in 1989, Epogen received FDA approval, since which time it's been used around the world in dialysis units. There are several different erythropoiesis stimulating agents, or ESAs, on the clinical market. These include recombinant human erythropoietins such as epoetin alpha or Procrit. There are biosimilars, and there are ESAs that have longer half-lives. These are longer-acting ESAs, including darbepoetin or Aranesp, and one called methoxypolyethylene glycol epoetin beta, or Mircera. They basically have great big side chains, so it's a very large molecule, and their half-life is a lot longer than the smaller molecule erythropoietin agents. The recommended target hemoglobin for a dialysis patient is ideally between 10 and 11 grams per deciliter. In the 1990s to 2009, there was interest in normalizing hemoglobin, so getting their hemoglobin up to 13, but there were several studies in the kidney disease population linking excess erythropoietin administration to achieve a hemoglobin of 13 to 60 with cancer, heart disease, strokes, and access thrombosis. One such study was the normal hematocrit trial published by Bessarab in the New England Journal of Medicine in 1998, in which 1,200 hemodialysis patients with known cardiac disease and baseline hemoglobin between 9 and 11 on Epogen were randomly assigned to achieve and maintain a hemoglobin of either 14 or 10. The study was actually stopped early after 29 months because there were more adverse events in the high hemoglobin group. Higher risk of death and non-fatal heart attacks, 70% higher 1 and 2 year mortality rates, a greater risk of access thrombosis, and the greater risk of hospitalization. So we know from this and other trials that there can be too much of a good thing. Erythropoietin stimulating agents are useful for managing anemia and preventing the need for transfusion, but if we give patients too much and we normalize their hemoglobin, there's a greater chance of having complications. That's why we have a target that's a little bit lower, between 10 and 11 for dialysis patients. The third medication I'd like to discuss for you today is vitamin D. Vitamin D is a steroid hormone that binds to receptors inside of cells. We all know that vitamin D is good for your bones, but it also regulates nearly 3% of the human genome. So it has many effects beyond just keeping our bones healthy. There were descriptions of vitamin D deficiency in the early 1600s in the form of rickets in children and osteomalacia in adults, but it took another 250 years to define the cause of vitamin D deficiency. In the early 1900s, when physicians and biochemists basically elucidated the role of sunlight and identified the chemical structure of the two main forms of the vitamin D molecule, vitamin D2 and vitamin D3. Vitamin D was first known to play a central role in calcium and phosphorus metabolism, but now we know that vitamin D deficiency is associated with numerous conditions in the general population, including falls, fractures, diabetes, autoimmune disease, cardiovascular and renal disease, depression, neurodegenerative diseases, and cancer. Vitamin D in our body comes from two main sources. 20% comes from eating vitamin D-rich foods such as oily fish and dairy products. D2 or ergocalciferol comes from vegetable sources, and D3 or cholecalciferol comes from animal sources. 80% of the vitamin D in our body comes from the skin's exposure to UVB radiation, so our skin makes most of our vitamin D. Vitamin D is so important that its deficiency may have contributed to the evolution of skin color. Those who live closer to the equator have darker skin, while those who live farther from the equator have lighter skin. Light skin is 6 times more efficient at making vitamin D from UVB rays than dark skin. So lighter skin may have evolved to allow for more vitamin D production in northern climates. After vitamin D is produced by the skin, the liver converts it to something called 25-hydroxyvitamin D, and then the kidneys convert that to 1,25-dihydroxyvitamin D, which is considered to be the activated form of vitamin D. It's 100 times more potent. Activated or 125 vitamin D then circulates in the blood and acts on different tissues in the body. It has multiple systemic effects. It reduces the production of parathyroid hormone. It increases intestinal calcium absorption. It increases bone mineralization. And it also probably has multiple effects on the immune system, cardiovascular system, neurologic system, as well as anti-cancer activity. Of course, dialysis patients have kidney failure, which leads to an inability to convert 25 vitamin D made by the liver to 125 vitamin D, the activated form. This has several consequences, including low blood calcium because you can't absorb it from the intestines, bone disease because you can't mineralize the bone, and overactive parathyroid glands. We administer hydroxylated or active vitamin D to our patients on dialysis. There are multiple commercial preparations available, including Hectorol, Zemplar, calcitriol, among others. Some, but not all, studies have shown a reduction in mortality with vitamin D supplementation. Supplementation in dialysis has been shown to improve bone disease. This was shown in a study published by Dennis Andrus, who is a nephrologist at the Seattle VA. Looked at 12 hemodialysis patients who were given intravenous calcitriol, performed bone biopsies at the start of the study and at 1 year of treatment. And what they found and demonstrated histologically was an improvement in bone disease, lower alkaline phosphatase, and lower parathyroid hormone levels. That said, no randomized controlled trials have shown convincing benefit of calcitriol in any synthetic vitamin D analog on survival, bone pain, or in preventing parathyroidectomy or other important clinical outcomes. We stop administering activated vitamin D to our dialysis patients if they have hypercalcemia, and in some instances if they have severe hyperphosphatemia or an elevated blood phosphorus level. Let's change gears and discuss intravenous iron administration. In order to make enough red blood cells in response to erythropoietin administration, dialysis patients need a lot of iron, much more than can be absorbed orally, and so almost all of them receive intravenous iron. Iron deficiency in a dialysis patient is defined as a transferrin saturation less than 20% and a ferritin less than 200. We use both TSAT and ferritin in evaluating iron deficiency in dialysis patients. There are several different commercial preparations of intravenous iron. The oldest one is one called iron dextrin or Infed. Fortunately, it has the highest incidence of adverse effects. There was a 1996 study of 573 hemodialysis patients who were given intravenous iron dextran, and almost 5% had adverse reactions, including itching, shortness of breath, wheezing. 1.7% had reactions that were anaphylactoid, so trouble breathing, low blood pressure. Another option is ferromoxetol ferrofene that can be given very rapidly just as by an IV push. There's one called ferric gluconate or Felicit, which we use on occasion at the Northwest Kidney Center. And the most commonly used one around the country is iron sucrose or Venofer. Probably has the best side effect profile. We check people's iron levels quarterly and administer iron according to protocol if their transferrin saturation is less than 20% and their ferritin is less than 200. Intravenous iron can cause many side effects, particularly if given quickly. That's one of the reasons why our nurses administer it slowly over the course of the dialysis treatment. Side effects include abdominal pain, nausea, chest pain, shortness of breath, flushing, pruritus or itching, a rash, low blood pressure. And you can even have an anaphylactic-like reaction, trouble breathing, low blood pressure. Antibiotics are also commonly administered with the dialysis procedure. One of the most commonly used antibiotics is vancomycin. It's a glycopeptide antibiotic used to treat certain bacterial infections. It works by blocking the construction of the bacterial cell wall during replication. It was approved for medical use in the United States in 1958, and it's on the World Health Organization list of essential medications. It's indicated for the treatment of serious, life-threatening infections by gram-positive bacteria. Common side effects include pain at the injection site. You can get something called vancomycin flushing syndrome, also known as red man syndrome, that basically presents as a diffuse pruritic rash if the vancomycin is administered too rapidly. And rarely you can have an anaphylaxis or a bad skin reaction called toxic epidermal necrolysis or DRESS syndrome, which is basically an eosinophilic drug rash. We minimize toxicity by monitoring trough levels. So those are typically ordered when we administer the vancomycin. Another commonly administered medication is cefazolin. It's a first-generation cephalosporin, which is similar to penicillin, used to treat a number of bacterial infections. It was patented in 1967, came into commercial use in 1971. It inhibits the ability of the bacteria to make the cell wall in times of replication, similar to vancomycin. Common side effects, diarrhea, vomiting. You can get yeast infections. You can have allergic reactions. It's on the World Health Organization's list of essential medications. It's effective against methicillin-sensitive Staph aureus, but not against methicillin-resistant Staph aureus infections, in which case we'd use vancomycin. And normally it's administered every 8 hours, but because the drug is removed from the blood by the kidneys, it can be conveniently dosed 2 to 3 times per week with dialysis. A similar medication is called ceftazidime. It is a third-generation cephalosporin which has broader activity against numerous gram-negative and some gram-positive bacteria. It also inhibits the ability of bacteria to make their cell wall in times of replication. It was patented in 1978, came into commercial use in 1984, and like the other two drugs on the World Health Organization's list of essential medications, has activity against both gram-positive and gram-negative bacteria. Common side effects include nausea. You can have allergic reactions. GI symptoms are possible but uncommon. Like with the cefazolin, normally it's given every 8 to 12 hours, but because the drug is removed from the blood by the kidneys, it can be conveniently dosed with each dialysis treatment. Next medication we'll discuss is one that many of you have heard of called TPA or cath flow. TPA is a protein that facilitates the breakdown of blood products. It acts as an enzyme and it converts plasminogen into its active form of plasmin, which is a major enzyme responsible for clot breakdown. It's normally found in the body. It's a serine protease that's found on endothelial cells which line the blood vessels, likely to minimize clot formation within our own blood vessels. It was first produced by recombinant DNA techniques, Genentech, in 1982, and it's manufactured using recombinant biotechnology techniques, producing types of recombinant tissue plasminogen activators such as alteplase, retiplase, and tenecteplase. So it's used primarily in hospitals to treat like embolic and thrombotic strokes. In dialysis units, however, it can be injected into a catheter whose blood flow rate is poor. So sluggish blood flow, the idea is to break up clotting within the tube that is suspected to be responsible. It's generally very well tolerated with hardly any side effects. The main side effect, I suppose, is cost. It's very expensive. One dose can cost twice that of the dialysis treatment. So we use it judiciously. In the final section here, we'll discuss several oral medications that are administered on an as-needed basis during the dialysis procedure. Clonidine goes by the brand name of Catapres. It's an alpha-2 adrenergic receptor agonist medication used to treat high blood pressure. So it lowers blood pressure by stimulating the alpha-2 adrenergic receptors in the brain, which results in a relaxation of many arteries. It was patented in 1961, came into medical use in 1966. In 2022, it was the 71st most commonly prescribed medication in the United States with more than 9 million prescriptions. The reason that clonidine is used so often for hypertension in dialysis units is because the onset of action is relatively quick, within an hour, and the effect lasts up to 8 hours. Common side effects include dry mouth, dizziness, headaches, sleepiness. Of course, you can have severe side effects with any medication, including hallucinations and arrhythmias. If a patient uses clonidine on a chronic basis and then abruptly stops it, you can have withdrawal effects, including a rebound hypertension. Dialysis is hard enough to get through when you feel well, but nearly impossible when you have diarrhea. Loperamide is sold under the brand name Imodium and is a medication of the opioid receptor class, first introduced in 1969 and clinically became available in 1976. It is an opioid receptor with no significant GI absorption. Also, it doesn't cross the blood-brain barrier when used at normal doses, and so it has minimal side effects. It works by slowing the contraction of the intestines. Side effects include constipation, nausea, and abdominal cramping. Zofran is a medication used to prevent nausea and vomiting. It is sold under the brand name Zofran, among others. It is a serotonin 5-HT3 receptor antagonist. It can be given orally, intramuscularly, or intravenously. It was patented in 1984 and approved for medical use in 1990. It's on the World Health Organization's list of essential medications. And in 2022, it was the 61st most commonly prescribed medication in the United States with more than 10 million prescriptions. Ondansetron is well tolerated, although can cause diarrhea, constipation, headache, drowsiness, or itching. It also can prolong the QT interval. That's the period of time in which the left ventricle contracts and then relaxes, and that can promote an arrhythmia, which can be potentially fatal. You can also have a severe allergic reaction. It's probably safe during pregnancy, but it's not been well studied in this group. And last but not least is acetaminophen or Tylenol. It's a non-opioid pain medication and fever-reducing agent. It was first made in 1878 by Harman Northrop Morse, or possibly in 1852 by Charles Frederick Gerhardt. Its impact on fever is modest at best, might lower the temperature by zero point 0.2 to zero point 0.3 degrees centigrade. It's decent for mild pain, such as a mild headache, mild muscle aches, or a toothache. It is the most commonly used medication for pain and fever in both the United States and Europe, and it's on the World Health Organization's list of essential medications. Side effects are almost non-existent. Rarely can cause nausea or abdominal pain if someone uses very high doses, and very high doses can also be hard for your liver. However, it is typically much safer than nonsteroidal anti-inflammatory drugs or NSAIDs, particularly for long-term use. Okay, let's review what we've learned today. Heparin prevents clotting during dialysis and is administered at the Northwest Kidney Center as a single bolus at the start of each treatment. Side effects include increased bleeding risk and low platelets. Erythropoietin, such as Mircera, is a hormone injection that stimulates red blood cell production. Target hemoglobin should be 10 to 11. Higher levels are associated with increased risk of heart attack, heart failure, hospitalization, and axis thrombosis. Vitamin D is an important steroid hormone. We give our patients Hectorol to control secondary hyperparathyroidism, and because of its beneficial effects on bone health, it's unclear if there are other health benefits associated with its use. Iron needs to be given intravenously to meet the red blood cell production demands of most dialysis patients. It is a common cause of nausea and abdominal pain, particularly if administered too quickly. Intravenous antibiotics are commonly administered on dialysis and include vancomycin, cefazolin, and ceftazidime. They all work by inhibiting bacterial replication. Vancomycin given too quickly causes a flushing reaction known as red man syndrome. TP or cath flow can be administered if a catheter flow is poor in an effort to dissolve clots that might be responsible. Clonidine is a fast-acting oral antihypertensive that can be used if the patient's blood pressure is really high. Loperamide slows the intestine and can help control diarrhea. Ondansetron is good for nausea. And finally, acetaminophen is used for fever, headache, and body aches. Okay, time for the monthly quiz. Question number 1. Heparin is produced primarily from what animal? That's right, from pigs in China, which is a huge problem. We should not be dependent on another country such as China for our medications, particularly heparin. Question number 2. Why do we give vitamin D to our dialysis patients? That's right. Primarily for bone disease. It decreases the effect of secondary hyperparathyroidism on the bone. It's been demonstrated to improve bone histology and bone quality. Question number 3. What are side effects of intravenous iron? Correct. Nausea, flushing, itchy skin, rash, chest pain, and hypotension, particularly if intravenous iron is pushed in too quickly. So that's why the nurses try to administer it very slowly over the course of the dialysis treatment. Question number 4. When would you consider giving clonidine to a dialysis patient? Correct. A. So if they have really high blood pressure, so clonidine is a short-acting antihypertensive with relatively fast onset of action. Next question. A patient receiving vancomycin develops a rash and feels flushed. What do you do? That's right. You temporarily stop and then you resume the infusion at a slower rate. The person has so-called red man syndrome. Important thing to recognize that it is not an allergic reaction. It's a normal reaction to rapidly administered vancomycin. Final question: how do vancomycin, cefazolin, and ceftazidime work as antibiotics? Correct. They inhibit the ability of the bacteria to form a new cell wall during replication. This concludes the May 2025 in-service for the Northwest Kidney Center. Thank you for your attention, and more importantly, thank you for your excellent care of our patients. This is Andy Brokenbrough signing out until next month.